To the RIAC Learning Series. My name is Vanessa Brewer. I am the Regional Interagency Council Program Administrator, and my co-host is Lee Taylor. Lee is the State Interagency Council Program Administrator, and we work at the Department for Behavioral Health, Developmental, and Intellectual Disabilities. So we want to thank you for joining us today. Today's session title is How Youth Treatment Coordinators Support Community Substance Use Concerns. Before I turn it over to our presenters for them to introduce themselves, I just wanted to go over a few housekeeping items. Uh, First of all, if you haven't muted your mic yet, please go ahead and do that. I did ask our presenters before we let everybody in if they minded, if people had questions, if they raised their hands during the session or put those questions in the chat box, and Lee and I will help to watch that. But if we could answer those questions as we're going through the session, and they said that they're completely fine with that. We also have time carved out at the end for Q&A. And if you've been part of this RIAC Learning Series before, you know we stop recording at that point, so we don't record that part of the Q&A. But anyway, if you have questions, please feel free to ask either along the way or at the end. Also, this workshop is being recorded, and it will be posted on the RIAC's Resources and Trainings channel, and we'll put that link in the chat box a little bit later in the session. We also have a session evaluation link that we'll post in the chat box towards the end of the session. It's very short, 4 or 5 questions. Please take a moment to complete that. And then, as always, if you need a certificate of attendance, please reach out to me. Those are available by request. You can email me, and I can put my name and in my email in the chat box a little bit later. So I'm going to go ahead and turn it over to Kate for her and Crystal and Aaron to introduce themselves. And I'll quit sharing.
Thank you so much, Vanessa. I am Kate Wagner. I work in the Department for Behavioral Health, Developmental, and Intellectual Disabilities with Vanessa and Lee. I get to work with the treatment coordinators as I am the Youth Co-occurring Treatment Program Administrator. I'm also staffed at the Kentucky Eating Disorder Council, but my role within the department is primarily around youth co-occurring substance use disorders. So I will hand it off to Aaron and Crystal to introduce themselves.
Hi, I'm Erin Northington, and I'm the Youth Treatment Coordinator here at Four Rivers. And I have been doing this for a few years now, so welcome.
And I'm Crystal Howard. I'm the Youth Treatment Coordinator for 7 counties, which covers Jefferson and part of Salt River. And been here same 3-4 years, I feel like, since the position was created. I'm also a supervisor for our child crisis and adolescent substance abuse program as well.
Yeah, you both predate me, so I appreciate you both being here. So my role here today is really just as the state person. It really is. I really wanted Aaron and Crystal to just really talk about all the amazing work they do for their regions. So if you have questions that specifically are maybe statewide or maybe for other regions, etc., feel free to ask me. But if you want brass tacks details, Aaron and Crystal are your ladies to ask.
We do have some slides, so I'll start sharing those now. Can everybody see those slides?
I can.
Okay, perfect.
So not to be death by acronym, we do refer to ourselves as the YTCs, the treatment coordinators, and of course RIAC has just kind of become vernacular. It's almost its own. You don't even have to say it out loud sometimes. It's as often as people are engaged with it. But I wanted to give you all a quick overview of our map and service area, color coded and numbered. So each of these are your region's youth treatment coordinator, and this thankfully is still up to date. So and there's your folks. But I do want to say, if I can connect you or do a warm connection, please do reach out to me. I'm happy to make that connection for you. And then,
And we're gonna put this up at the end too. That way, if anyone needs to
perfect.
reference and figure out.
Yes, thank you. So this is just a kind of a quick overview of what the youth treatment coordinators do. So statewide, they're a really awesome mix of clinical social work, clinical counselor, the licensed, all the fun licensed things, and certified youth and adult peer supports. So they together as a group, they really bring this amazing knowledge base around clinical experience, supervision. Sorry, I'm getting a test emergency alert. It's a test. Shut up. I mean, like of all the times to do this. Sorry. Oh, good. It's not just me then. Okay. I can hear it too. So yay, it works. Sorry.
No, they made an announcement that they were supposed to do it the other day with all the bad weather coming in, but they postponed it to Friday because of the bad weather.
Okay. Thank you. And thank you for normalizing my mild panic attack. So clinical peer support and just overall really amazing community connectors. And that's what their job is. So at least 50% of their time has to be dedicated to working in their community. So whether it's through your RIAC or through a fair team or any other ASAP, et cetera, and they'll all go into that. But they're really meant to be community and outreach. Knowledgeable about youth co-occurring mental health and substance use issues, knowledgeable about their providers within their agency. It also happens that Crystal and Aaron can be the providers themselves, but because 50% of their time is dedicated to the community, they have to keep a smaller caseload. And again, I think, I can share this as well. So we can move on. And I'll turn it over.
Okay. So one of the things that we spend a lot of time doing is providing, I'm sorry, someone keeps knocking on my door, so please hold. I have a feeling we might be doing a drill. This might get real interesting.
I mean, best laid plans, right?
This is perfect. Okay. So part of what we do and part of what we assist other people at our agency to do is to provide substance use screenings, assessments, and then treatment. So a few of those screening tools are the CRAFT, which I did have to look up what all that stands for because I cannot remember always what it stands for, but that stands for CAR, Relax, Alone, Forget, Friends, and Trouble. And those are some of the key words that are in part of that screening tool. So the CRAFT, that one is free. It's can be self-administered or an interviewer style. It is used to assess the risk and then interpret the probability that a person might have a substance use diagnosis. Then we have the CAGE. So again, had to look that and make sure I had that correct. But that one is 4 questions. They're yes or no questions. And again, that goes along with the questions, what that stands for. So have you felt that you should cut down on your drinking? Have people annoyed you by criticizing your drinking? Have you ever felt bad or guilty about your drinking? And then have you had to drink first thing in the morning to steady your nerves or to get rid of a hangover? So the E stands for eye opener. Let's see. And I'm trying to make sure I don't want to. Oh, Crystal is back.
I am.
I'll go ahead and do the SBIRT and the GAIN, and then if you want to take over.
Sure.
So the SBIRT is another screening tool that can be used. That one is not free like the other two, but it's a really great screening tool. That stands for Screening, Brief Intervention, Referral to Treatment. And then that screens for the severity of a substance use disorder and then can help connect you to appropriate level of care. It also provides the brief intervention to increase the insight and awareness and motivation for change, and then referral to treatment. And then we have the GAIN. So there's several different types of GAIN. So there's the short screener, which is the SS that's listed on here, the GAIN Q, which is the quick, and then the GAIN I, which is a comprehensive biopsychosocial assessment. So I don't think we have that listed under the assessment piece, but that can also be used as an assessment tool.
So on to assessment. The ASAM is a very in-depth, lengthy tool that yeah, I don't know that you have to be trained in it, but you should be trained in it to use. But it will give you the level of care that is appropriate for that substance use issue. It assesses like physical withdrawal symptoms, physical health, environmental factors, motivation for change, all of that. And then I can't say this next one, that ACATOS. That is a Kentucky specific screener, I believe, that will also, it's really in depth, takes like, I believe an hour-ish to complete, and will just give you recommendations on appropriate level of care. Anything you want to add on that? Because I've never used that one.
No. So it is, like Crystal said, it's about an hour. It's a really great assessment tool. It has structured interview questions that you go through and you ask. And then it gives you a kind of like a printout afterwards of recommendations for diagnostic purposes and for treatment and level of care purposes.
So for treatment, a lot of really common interventions that you will hear in Kentucky is 7 challenges. That's a really common one across the state. There's a lot of different agencies that use it. ACRA is also a newer one that a lot of agencies are starting to use. It's focused on community reinforcement. That's what the CR stands for in it. And it really connects them to just community supports, getting a job, identifying healthy social supports, things like that. 7 challenges can be a lengthy program, and it's in a lot of different levels of care. So that could be inpatient or outpatient. Brief 7 challenges is just a brief version of it, and it's just I think it's 4 or 5 sessions, so it's really short. Contingency management is a really common one that's been around for a long time. It's about rewarding behavior changes, and motivational interviewing, of course, I think is the gold standard that probably everyone has heard and is used for almost everything under the sun. And then moral recognition therapy is a new one, new-ish, and DBT can also be indicated to help with substance use, helping to build that distress tolerance of whatever is causing the substance use to happen. I'll keep going to this one. We also wanted to go over some other screening and assessment for just co-occurring, because that is part of what we do. It's not just substance use, and we also recognize that there's usually other things going on connected to the substance use, and so this can help screen for some of the other things that the kiddos might be struggling with. So the CSSRS is the Columbia Suicide Screener. I can't remember the whole acronym.
I looked that one up too. Columbia Suicide Severity Rating Scale.
But that one I think is a really evidence-based kind of standard for easily screening for suicide. The PHQ-9 is a great depression screener. It's a 1-pager. The GAIN comes up again. The GAIN stands for Global Assessment of Individual Needs. I can remember that one. It does screen, if you do a full GAIN, for lots of things. That is also a very intensive screener that I've never done. And then PRIME is common for first episode psychosis, and there is a lot of co-occurring with substance use and psychosis, specifically THC, with a lot of the higher potency vape pens and things like that we're seeing. So psychosis and marijuana use can be friends. As far as assessment, just doing a risk assessment. You want to add anything, Erin?
No, I think, as far as assessment, sorry, I have something in my eye. A risk assessment to determine risk of harm to self or others, and then also as it relates to substance use. And then you've got your mental status exam, which really looks at all of the areas of functioning for an individual and where they are at that time of that assessment. And then again, the CAMS, DBT, motivational interviewing, and there's a long list of others that we did not identify on here that can be used as treatment options for individuals who may have co-occurring disorders. Anything to add on that, Crystal?
No.
All right. So now to the YTC and RIAC. So why is it important to involve your youth treatment coordinator? And Kate has gone over some of this as well. So the YTC is knowledgeable about available services for youth who are experiencing substance use. And another really great benefit is that we are all connected to one another. We have this statewide network to be able to assist other agencies or communities with connecting them to services. We can also be the access point to local community mental health services. We are stationed inside of the community mental health centers across the state. We can support the RIAC and other community partners with supporting with problem solving within the RIAC for substance use and co-occurring symptoms. We can offer and provide trainings on substance use and co-occurring symptoms. We can provide you with information to be able to give family members or caregivers education on adolescent development, substance use, and co-occurring symptoms. And then we also work closely with the schools to provide education and treatment options. Anything to add there, Crystal?
I think just that, like, even if the kid isn't presenting with maybe substance use issues, that we could still potentially, especially with adolescents, be a good contact person. Because a lot of times it could still be going on under the surface. They just haven't been caught or found out yet that it's happening. So it's always good to just screen, I think, any contact with youth or adolescents. And the evidence is showing that vapes are starting to find their way into elementary schools, so that the age of initiation is getting lower and lower. So it's never too early, I think, to start screening for these things.
That's a good point. All right, how the RIACs support YTCs. So RIACs, so for example, Crystal had mentioned whenever we were talking about this that the RIAC had provided certain materials to help support youth and families who are experiencing substance use. For example, Alateen books. The RIACs also provide the youth treatment coordinators with opportunities to network with other community members and partners. There's such a vast network of people that are involved in the RIAC that it's really great for us to be able to connect with all of those community partners, just to provide support and education and resources to youth and families who are experiencing substance use and co-occurring disorders. And then we also can learn about and also provide information on needs within the community to the RIAC. Any other ideas from anyone? This is kind of a point where we would like some feedback on how you all feel like the RIACs can support the youth treatment coordinators.
So I have a question about how they could support each other, the RIACs and the youth treatment coordinators. I know that one of the mandated members on the RIAC is a transition age youth between the ages of 16 to 25 with lived experience, whether that's mental health or anything that falls under that umbrella of behavioral health, and if they've, of course, received a service to address the need. And so I'm wondering, with some of the youth that you guys work with, do you feel like that there's an opportunity to maybe connect some of those youth to the RIAC so that they can be a voice for their region on the lived experience that they have to help kind of shape that regional system of care?
I think potentially, yeah.
I know that there are several RIACs throughout the state that are currently looking for that youth voice on their RIAC. So whether they serve as a youth rep or just come to the RIAC to provide input based on what they are seeing regarding needs or trends, or how their experiences went or didn't go with services and supports, again, just to kind of help raise their voice within the community to support things that maybe might be needed. I also wanted to ask, and I learned about this last week, and I might have this wrong because I know that we had youth treatment coordinators, transition age youth coordinators, and youth empowerment specialists at a collaboration meeting that I was at. But do you guys have access to like data or community needs assessments that can be shared also with the RIAC when they are looking at selecting an area of focus for their region, or defining their goals for impacting their regional system of care?
I think potentially. I mean, I know we have to do a needs assessment, but it's based on the agency. But I also know my agency has done some community needs assessments that I would have access to. So I think it's definitely a conversation that would be worth like at least asking if that information is available, because depending on the agency, yeah, I definitely think that could be a
Right. And with the youth treatment coordinators, we do partner closely with our TAG coordinators and the Regional Prevention Center. And so I feel like between the three of us, we probably have access to a lot more information than we even realize. So I think that's definitely something that we can help at least facilitate and find out information for the RIACs.
And I wanted to kind of jump in on 2 points. One is, even if the YTCs don't necessarily do, or their agencies don't necessarily do region-wide needs assessments, then we can also give data points based on some of our statewide surveys, like the Youth Risk Behavior Survey, the YRBS, or the KIP, which is the Kentucky Incentives for Prevention Survey. And what makes both those tools like really very, very useful is that they do semi-model each other. But with the YRBS, you can get statewide, and you get statewide data. The KIP, you get statewide data to compare to the YRBS, but then you can drill down to the region level, the county level, and just see how your region or your county looks compared to the rest of the state. So I just wanted to share that too, that, you know, that's a very good opportunity with the network that they have, and then the relationship between the YTCs and my position at the state can be helpful. I also just wanted to kind of chime in on the transition age youth in the RIAC, and maybe some of the youth that Aaron and Crystal see. And I think youth voice, especially with lived experience of co-occurring mental health and substance use services, is so needed and so necessary. The only kind of, I guess, reservation I would have about that is just depending on where that young person is in their own treatment journey, and just being very careful that we don't inadvertently set them up for relapse by adding on a stressor or any other barrier. So, and I don't want to speak for Crystal, but I recognize kind of the hesitancy, and just wanted to say, like, we would want to be careful about that.
I was also thinking of it as like, I still see clients. I have a clinical caseload. So that would be weird for me to be in a meeting with my own client, but there are other people that I work with. Like we have a tailored drop-in center, so I could easily talk to them and bridge with someone who maybe is not on my caseload, but would still be very appropriate.
Any other questions or ideas on how we can support one another?
Yeah, I was thinking like some of the statistics between counties could come in handy to bring and share with the fair teams, so that as we're going over cases, we can be aware to ask the questions that might relate to this area. Like, I noticed that sitting on 3 different fair teams through the month, that some of the questions, like, we think mental health and, has this child, do they have a need to get assessed for, mental health issues? But we haven't really went into, do they need substance abuse, monitoring, or some of these kids are coming from houses with the parents in jail or with addictions already. Are there other programs that these kids that are high risk could potentially be put into? And you guys would probably be holding the plethora of resources for that, so it might open up a new door to add into for their diversion programs if they're at more high risk for those issues. So I would like to see you guys potentially come to some of our fair teams and share some of that information with our coordinators and our court designated workers and the other people, just so that we can be aware to just monitor in more of an all-around circle for these children, to make sure that we're hitting on any needs that they individually need.
Yeah, and I think that's a great point. And I can't speak for all of the YTCs, but I do think there are some of us who are connected with our CDWs and our fair teams. And so, and it might be where maybe the YTC could be invited in on those fair team discussions. So yeah, I think that's really great, and we do have access to a lot of resources and treatment providers, treatment options within our communities. So I think that's great.
And to that, Amanda, it is part of their scope of work, the YTCs, to work with their fair teams and be connected to CDWs. So if a YTC is not connected with their fair team, then I would love to somehow figure out a way to get them connected to their fair team.
Excellent. And me saying that doesn't mean that they're not. There are people on the fair teams that I don't realize who they are or what their job is, because I don't know them personally either. So, I mean, they very well could be on some of the fair teams, and I'm just oblivious at this point. So, but no, if they're not, I would love to see them there though.
Any other ideas or questions before I move on to the next slide?
Sorry. I just had one more point to make.
That's okay,
And
Kate.
it goes back to what Crystal was saying earlier about like with vapes and seeing them show up in younger kids. So I unofficially declared that the youth treatment coordinators work with population age 10 to 26 or 10 to 25, excuse me. 25 because that is the Substance Abuse and Mental Health Services Administration and our own policy around what constitutes transition age youth. 10 because the World Health Organization said adolescence starts at 10. In this, and this is Kate's opinion, until I have data to back it up, it remains Kate's opinion. I think they should be working with younger kids. I think there's always an opportunity to prevent substance use needs, and that's where your regional prevention center can come in. But just because they're a little kid, it does not mean that they haven't gotten access to a parent's needs, or they're not a child of an alcoholic, or and I don't mean to say alcoholics, it's really horrible language, but adult children of alcoholics was a thing for so long. Now it would probably be an adult child of a I don't know. I'm sorry. My person first language is failing me right now. But we don't know if they're in a home where substances are available. We don't know. We don't always know if parents lock up any substance, any medication. And this is not to say that parents are always using. It's I have to take my meds every morning. I just need to make sure that my kids can't reach it. Same with any alcohol in the house. So we get busier, and then kids still get into stuff. And so that is where, through sometimes just no fault of one's own, the YTCs can come in and just start asking really good questions, or educate your community on how to ask some good questions that would get at a potential issue. Because I 100% agree. Ease of access has increased, and vapes are everywhere. So I just wanted to add that point, and I will stop talking. Yeah.
Thank you, Kate. All right, so the day-to-day for a youth treatment coordinator, and this is different for all of us. Myself and Crystal, we are both clinicians as well who carry a caseload, and then some of our other YTCs are peer supports, as Kate mentioned, and just, doing different things depending on what they are able to. But overall, we are doing community outreach and making connections with community partners, community members, schools. You'll see below fair teams, ASAP. A lot of us are set in on ASAP, the RIAC, Fair Juvenile Court. And then it does talk about here that YTCs are billable as peer support, clinician, or there could be other things in there as well. And then we can provide direct services, but as Kate has mentioned a few times, we do have to have half of our time doing indirect services, outreach, those community connections, and partnering with our community partners. We can attend meetings, all of those listed. And then I know for myself, I do go to juvenile court here in McCracken County once a week. And that has been a really great way to connect people, young people and families, with services that may be available to them. Plus, in juvenile court, we have a lot of the fair team members who are coming. We have the CDWs who are there. We have Department of Juvenile Justice that's there. And then DCBS as well is usually represented there. We can be the access point for any treatment services within the agency, specifically substance use and co-occurring services. And then just really trying to meet people where they are to connect them with services that will be most beneficial for what they are experiencing at that time. Crystal, would you like to add, or Kate?
One thing we haven't talked about, I think, is our requirement to engage with DCBS. We've talked a lot about this, but we are expected to have contact with DCBS and the school systems. So those are also contacts that sometimes we can be good to connect to in the area.
Thank you. Okay. I feel like we went through that all very quickly. So, again, this is the map of your contact person, your YTC in your region. Hopefully you can see that my eyes are really terrible right now, so I cannot. But we can also potentially try to send that out, Kate, I'm guessing, or reach out if you would like that. So any questions?
Have you all tried to network and work with Community Collaboration for Children as well? That might be a good community partner to join their regional meetings.